As Dr. Podar already mentioned, we've got an amazing last final plenary for you for today. We'll start off with why we're doing this, right? So we're doing this again for our patients. And it's often very important to understand that our priorities may not be the same as that of the individual living with diabetes, with obesity, my bad. And hence, it's really important to consider the patient voice. So distinct honor for me to introduce our next co-panelists here, the next speakers. We'll start with Ms. Sandra Elia. She's the board chair for Director of Education and Patient Advocacy of Obesity Matters. She's a certified food addiction counselor. She runs Canada's outpatient food addiction recovery program and co-created Canada's first inpatient treatment program. She's the author of Never Enough: 3 Pillars of Food Addiction Recovery. She's very dedicated to changing the conversation about obesity so that anyone living with obesity has access to treatment that is delivered with dignity, respect, and understanding. And joining her today is Dr. David Macklin. Dr. David Macklin is a lecturer at the U of T Faculty of Medicine and the University of Toronto trained family physician. He's a medical director of the weight management program at the MedCan Clinic and the Medical Weight Management Centre of Canada, staff at Toronto Mount Sinai, and is a science committee member at Obesity Canada. He's the co-author of the Canadian Action Study that Dr. Wharton showed earlier this morning, and also a co-author of the Behavioral Treatment chapter in the 2020 Obesity Canada CPG. So with that, I'll have Sandra and David take it from here.
Thank you so much, Akshay. Much appreciated. This has been such a really great conference. I want to congratulate the organizers. This has been just a great group, and plus all the professionals in the back. Everyone's been very friendly. I was at a conference recently where I was eating a sandwich, and some low-carb guru came up and said, you know, that stuff can kill you. And I said,
Yum.
I said, but my grandfather lived to 104. He said, by eating bread? I said, no, by minding his own business. So today is the last presentation. We're going to be really demonstrating. We're going to be putting front and center the patient voice. There's been a movement in Obesity Canada. And it's really a particular Canadian phenomena where there have been many, many years now where we have been placing the voices of those who are living with obesity into our presentations, mingling it with our science, and thereby helping the practitioners that come and attend educational events learn more about the perspectives, the internal dialogues, the experiences of those living with obesity. And if you're reading our guidelines, you'll see that this is really front and center. And today we're going to be bringing this to life. So I hope you guys really enjoy this for our last session. Sandra, I don't know if you want to introduce also yourself?
Yeah, so I am definitely passionate about being a patient advocate. I not only have my own history of living with obesity, but I was a caregiver for my mother who lost her battle to obesity at the age of 69. And so when I was very young, I was her patient advocate, and I was also her translator because she didn't speak English. And as a child, I witnessed quite a bit of bias, fat shaming, scaring, but I didn't know that it was inappropriate, and I didn't know that it was actually driving her further and further into her disease. So this work really is quite personal to me.
Wonderful. And so how does this play out clinically? I'm so sorry you were subject to that. And today we're going to talk about what are the effects of being subject to bias and stigma in the conversations. Just very quickly, these are our disclosures, both myself and Sandra, and these are our objectives. Please note in the first objective, recognizing not just recognizing, but addressing stigma. How are we going to do that? How are we clinically in our practice going to address stigma? We're going to show you today a little bit about that in a very active role-playing process to make this a little bit more fun. Number two, it becomes about the relationship and the conversation. Utilizing the appropriate language and communication strategies when focusing on obesity with patients to foster this empathetic relationship. How do you do that? Well, we're going to be demonstrating that today too. And then finally, really what I talk I would phrase that last objective, implementing these patient-centered care approaches to set realistic goals. I'd say, how do you empathetically and appropriately kind of end on homework that the patient might choose themselves to do? We're not telling them what to do, but how could we help a patient decide on some homework between our visit now and our next visits? And so certainly I won't spend too much time on this. We know the new guidelines have focused on people living with obesity and how they face substantial bias and stigma. And I am the proud author with Michael Vallis of the behavioral chapter. Of course, medication and surgery, people generally know those two pillars. And of course, diet and exercise are not there because one of the key parts in our behavioral chapter was, and this was the first time we had ever read this anywhere when Michael and I put this into our behavioral chapter, we suggested that changes in eating and changes in exercise can be considered outcomes of treatment. And that's why they're not here. If behavioral therapy and medical therapy, for example, or surgical therapy are working, patients are able to make sustained changes in their eating and their exercise, which moves us all away from the eat less, move more, right? Just like we don't tell patients to, with depression to cheer up and snap out of it, or patients with asthma to breathe deeper and cough less. We don't tell patients living with obesity to eat less and move more. And we'll be framing all of this in a little bit of a crash course in the basic concepts. Everything's lifted from the Canadian Clinical Practice Guidelines behavioral chapter. We're going to be framing our conversations in motivational interviewing techniques. The techniques of ALSI, you might have heard it called, ask, listen, summarize, invite, and inform. And so we're going to jump in, and Sarah's joined me in my clinic, and this is an early presentation. Sandra has presented, wanting to ask about her weight. I've still asked permission if that's okay, and she has said yes. And I'm simply opening the conversation by saying, tell me more what brings you in and what it is about weight that you'd like to talk a little bit more of. I'm the physician, and Sandra is the patient. So tell me, Sandra, good to see you again. How can I help? Tell me a little bit more about what you were interested in discussing around weight or weight management.
Yeah, so what brought me in today is that I'm at my heaviest weight ever. And this all started a couple of years ago. I was starting a new job, and so I started a commercial diet program. And during that 6-month period, I was able to lose 50 pounds. I was elated, excited, started my new job, and then a rebound started. And not only did I gain back the 50 pounds, but I gained an additional 50, so 100 pounds in about a year and a half. And I have to tell you, that was one of the most humiliating experiences of my life, because I could see the reflection in my coworkers' eyes as I would show up to work month after month, heavier and heavier. And it started to affect my mobility. I live with chronic lower back pain, so I can't really move as freely as I want to. I'm starting to isolate from my friends, from family, from activities. I don't participate in much. My mental health is taking a complete nosedive, and I'm thinking about doing a sick leave just to kind of catch my breath for a little bit. I would have to say my weight right now, it's just unmanageable, and I do not have another diet in me. I've been dieting since I was 15. I get it now, like it only leaves me heavier than when I started. And even when I try to control myself, I'm overwhelmed by cravings. They're very intense and immediate, and I just feel unmanageable.
So Sandra, first off, thank you very much for sharing. You described quite a significant experience of you struggling with your weight, and I want to thank you for sharing that with me. What I hear you saying, and as I jump into this, by the way, you are about to hear what I'm going to suggest is one of the most powerful tools that you'll ever have in clinical medicine whatsoever, certainly obesity medicine, which is called the summarize. You've heard the ask, you've heard the listen, and now you're going to hear what we call the summarize. It leaves summary out of your clinical practice at your peril. Sandra, what I heard you say is you're at your heaviest ever. And this really all started a couple, correct me if I'm wrong, what I hear you saying, and I really want to make sure I have this right, is that this kind of started a couple of years ago. You started a new job, you started a commercial program, you lost around 50 pounds of weight, you described, and you said you endorsed feeling elated and excited about that. And then there was really what you describe again as a rebound. You gained 50 pounds and then another 50 pounds. And then you describe it as humiliating. I felt like a very strong kind of negative experience I started to get from you. And you could almost see the reflection in your coworkers and how they were looking at you, right? And this was affecting you, it was affecting your mobility. And even you described an isolating effect, kind of almost removed more or withdrawn from friends or family. You endorsed that your mental health really took a nosedive. You're even considering a sick leave. And you describe your weight as unmanageable. And really kind of don't plan on taking another diet or starting another diet, because you really see that just leaves you heavier. You're overwhelmed by cravings. I wanted to make sure I had what you told me kind of correct. Is that about correct?
Yes, and I'm just going to go off script for a moment.
Sure.
I feel so emotional hearing you say that back to me, because we didn't actually rehearse this. And so I have to tell you, like, I'm almost moved to tears, because I don't think anyone's ever repeated my story back to me in that way. And it's very shocking to be emotional in this moment, even though it's in retrospect. So, wow, this is, yeah.
Thank you for sharing that too. And that's the power of the summary.
Yeah.
Because how many times has Sandra been in a healthcare practitioner's office where she told her story and the person said, okay, well, let's talk about some diets then. And let's go on to solutions, without actually confirming that what Sandra said was heard, was listened to via the method of summary. And often what I find in clinical practice is once you've summarized, someone realizes that they're being listened to, and then they'll share more, right? That's, oh, well, another thing then, now that you're listening, they won't say now that you're listening, but they'll add more, right? And so in the back of my head, this is what's going on in this initial presentation. You see, I know, as we've discussed today, that obesity is understood to be a real disease. 70% we know of someone's risk of struggling with weight in their lifetime is conferred genetically. And we know that the absolute great majority of these genes are in the central nervous system. We inherit, as you've heard today, this unique appetite system with 3 layers, with the executive system and the reward or motivation or hedonic system, and then the homeostatic system at the bottom. And these 3 layers developed for an environment where work was required for food. No one worked for their food today, and you take that for granted. But human experience was always that we needed a motivation system that made us work for our food. We needed to be motivated to go. So here in this weight system is where our weight is regulated, our cravings, our motivation to food. And finally, of course, and I always share this as bad news with my patients, this is also where our brain defends against fat loss. If there's one key bad news piece you've heard today, and boy, do we need to share this with patients, is I'm wondering if you would consider that as you struggle with weight and manage weight, that your brain is expert at recognizing fat loss and fighting against it with increased appetite primarily. Yes, decreased metabolic rate, but to a much lesser extent. Increased appetite, increased interest in food as someone loses weight. In fact, we now know this is Arya Sharma quoting him, that's actually the logic of anti-obesity medications. Anti-obesity medications exist on this planet. Why? Simply to defend you against what your brain otherwise will be doing. And I also know that this ancient appetite system has collided, as Sandra sits in front of me, with what we call the obesogenic or modern food environment, where foods are hyper-palatable, as we heard earlier today. Ultra-processed, ultra-portioned, ultra-available, advertised to look healthy and delivered to your front door. So as I'm listening to Sandra, not only am I listening for the details of her experience, because it's so critical, I'm also, in the back of my head, knowing I really want to communicate to this patient the following. And so we've asked, we've listened, we've summarized, and I like the phrases. By the way, the summarize is preceded by I'm wondering if, what I heard you say, correct me if I'm wrong, tell me if I have this right, as a precedent to the summary. And then we have the inform, invite, the invite, inform. We heard physicians today sitting here saying, I'm not an obesity specialist. Give me an FAQ. Give me what I should say. Give me what I should do in these circumstances. I don't want to turn red-faced like we heard about a cardiologist earlier today when questions come and I don't know what to say. And so here is that FAQ answer, but we don't say FAQs in obesity medicine. We say inform, invite, or invite, inform. because this is motivational interviewing. So the FAQ would be, well, now I'm just going to answer your question. We've gone through the motivational interviewing process instead, and now I'm going to turn to Sandra after summarizing what she said, and I'm going to ask her just what we talked about just now. I'm going to ask her if I'm wondering if you would consider the following. Sandra, the science around obesity medicine has changed quite dramatically. We now consider struggling with weight, I won't repeat in great detail, to be primarily a genetic, brain-centered, strongly environmentally influenced, progressive, real medical condition. And would you consider, and here's the stigma, here's the countering, how are we countering internalized weight bias? I'm wondering if you would consider that struggling with weight is not your fault. I'm wondering that it's not because you have less willpower or you're not motivated enough or you're weak, but instead because you're living with a real medical condition untreated. That's unfair. And, by the way, treatment exists. We have 3 pillars to treatment, not diet and exercise, not eat less, move. There's behavioral therapy, there's medical therapy, and there's surgical therapy. Then, if I was a physician who had only 3 minutes, at this point, I would say, here's some material about obesity as a real disease. I'm wondering if you would organize a visit where you could come back and we can talk in much more detail about treatment principles. And here's the information about obesity as a real disease. And if you could make an appointment, you have a red carpet welcome to come back and talk about this. That's if it's a quick visit. And if I have more time, and if I'm shy and it's the last visit of the day, we go into more. So what I wanted to do at this point is I wanted to ask Sandy, what would that have been like if in the past you presented to a physician and that's the methodology that you heard, and more about what you heard in the past?
Yeah, I think I want to start by contrasting what I experienced to really hit home how this experience is different. So when I did end up going to the doctor about my lower back pain, she said that that was not a medical issue, that was a weight issue, and that I needed to lose weight. And I was already very much filled with shame and embarrassment about my weight. And so when the question came up, don't you care about your health? I started to question if I did. Because look where I had gotten. Maybe I didn't care about my health. Or the other one, I guess she thought this was motivational. If you really, really want to lose weight, you would lose weight. You make the decision and you do it. And I thought, there's nothing else I want more than this. Like, I think about it every single day. So in this contrast, I mean, for me, it starts to build rapport with the doctor, trust. It makes me feel like, okay, this could be a medical condition, but this is going to take me a while to wrap my head around. It's absolutely going to take some time because I grew up in the diet culture that it is willpower. And I had a family that said, put the fork down, and that exercise was the answer. And so now I literally have to have a paradigm shift, and I have to reconstruct how I think about myself in the context of what I am struggling with. This would definitely build trust again, and I would probably start going to the doctor more.
Oh, very cool. Great feedback. And so we see the potential shift by, as our objective said, kind of recognizing bias and stigma that's been internalized and creating this relationship and using motivational interviewing as the technique. Thank you for letting us go through that example, Sandra, pardon me. So we wanted to go through another quick one. So just to give you guys, because has this ever happened in your clinical practice? A patient comes in and says, I'm not losing weight. Doc, or dietitian or nurse, I'm not losing weight anymore. I'm stuck. Right? Is anyone's blood pressure going up as I described that, right? This presentation. So let's role play this a little bit, right? Maybe Sandra, maybe if you could present and be coming back. And I've already, as you come back, just reminded you, just a reminder, thanks for coming back, but we consider struggling with weight to be a real condition, not your fault, treatment exists. Just to remind you, because I know that's not public discourse, and you won't hear that out there, but just when you're in this office, that's certainly amongst myself, amongst the staff here, that's our understanding. Real condition, not your fault, treatment exists. Tell me a little bit about how things are.
Well, things are great. I've lost a considerable amount of weight, but I have the last 30 pounds to go, and I'm not happy at my current weight. I'm actually quite frustrated. I keep doing all the things I did before, but the scale will not budge. And I can't seem to control that number, and it literally makes me want to throw in the towel. Why would I work this hard not to see the scale go down? And you know, it's not about knowledge. I have all the knowledge. I just want to know, how do I get to my goal weight?
What's next, everyone?
Yeah.
Thank you. Good. So what you're telling me, Sandra, and thank you again for sharing, correct me if I'm wrong, what I hear you saying is, things are great. You've lost weight. And now you feel you have the last 30 pounds, as you describe it, to lose. 30 pounds to go. And you describe that you're not happy at this weight. And also you describe it, right, and I hear you saying this quite clearly, like, listen, I'm doing the same that I was before, but I'm just not, the scale is not budging. This is the same level of effort, I'm doing the same. And I can't control the number, and I hear kind of demotivating, because you use the word kind of throw in the towel. It's creating maybe an emotion of demotivation, right? And like you said also, it's not about not knowing what to do. You know what to do. It's just how do you get there? Right? That's what you're describing. And so I'm wondering if you would consider the following. Now, it's quite rare that I'll meet a patient where I have not gone through this. I cannot imagine a visit that I have not gone through. In fact, in my initial consultation, I'll review this FAQ equivalent, invite and form. I would probably, in every visit, in a very short form, review exactly what we were looking at on this slide, and this would be my invite and form, and I'd ask Sandra, you know, would you consider, I'm wondering if you would consider that all weight loss slows and slows, and eventually plateaus. And it's because of this horrific, unfair, bad news that I shared with you that I feel very bad about, even personally, that the brain defends against fat loss by recognizing, by the way, losses of leptin, which our brain is super sensitive to. And in response to that, appetite goes up, and metabolic, but again, metabolic rate goes down, but primarily appetite. And so I'm actually, you know, we now talk about weight as not a behavior. It's not something, I know this will sound weird, but it's not even, we think of as something that someone has control over. We say we have control over our behaviors. And so I'm wondering if you might fashion I wouldn't wait till she's in a plateau to go through this, but that's the artificial scenario we have here. And it might happen that way. I'm wondering if you would consider your path forward, framing your path forward to be a process of finding or iterating or practicing or developing the skill of really what is the least amount of calories that you can take in, the healthiest eating that you can put together that still maintains a loyalty to fun and food and friends and socialization and celebration and travel and the things that you value from fun and food or drink. And all at a level of effort that is sustainable. Why? Because whatever you put together, I don't know if this is good news or bad news, you'll have to do for the next 40 years, 50 years. So whatever you put together, in that way, you might consider it should be sustainable. And so would you consider organizing your most modest lifestyle that's still fun and enjoyable and sustainable and maintainable, a level of effort that you can keep? And then, might be the difficult part, and then just standing back and letting your brain and body tell you how strongly are your genes going to defend against fat loss? The thing is, we don't know. It's actually a primarily genetically conferred trait in the lower parts of our brain that we share with mice. And so would you consider standing back in this context and doing your best and letting your brain and body kind of tell you where that lands? It's something we in Canada call someone's best weight. We've thrown out target weight, goal weight, and ideal weight and replaced it with the concept of best weight. What are your thoughts about that? I know it sounds a little upside down and maybe difficult, but what do you think of that as a concept?
So it's a difficult pill to swallow. But I think what would be helpful for me is when I came to the clinic if they didn't want to take my weight. Because when I walk into a clinic and I'm asked to step on the scale first, that signals to me that that is actually the most important marker. So I would like to skip that completely out of the equation so that when you and I talk, I won't have that number in my head that won't allow me to hear anything that you're saying because I'm disappointed in the number. And then we can only focus on the ways that I'm improving outside of that number.
I really like that idea because what Sandra and I were talking about earlier, first of all, I, by the way, won't weigh patients, and we work remotely, and patients, if they wish to report their weight or even get on a scale and take their weight, that's very much up to them. In fact, we tell them if you anticipate that getting on a scale might create a negative emotional response, please consider not jumping on the scale, because what Sandra and I could be talking about, remember how she started this interview? She actually said things are great, which means that there's probably quality of life and health benefits going on, and we got distracted by talking about, well, I had to go through best weight principles because maybe we hadn't covered it, but certainly I think you had mentioned this earlier, would really appreciate discussions about benefits that you're experiencing from quality of life and health, and starting to bring those to the surface.
Yeah.
Right. So, again, I would provide information around best weight and the brain's fighting against fat loss with increased appetite and decreased metabolic rate, the concepts of best weight in more detail, and invite her to come back, talk about the health benefits that she's experiencing, the quality of life benefits that she's experiencing. There's many other areas. There's only 6 other areas. In our guidelines, we've created a knowledge translation. Michael and I, just recently, last week, Michael Vallis and I reviewed, and we are now committed to creating more of a formal knowledge translation as the expansion of the behavioral chapter in the Canadian guidelines. And these are 2 of the 8 components that will come out of that: how to address internalized weight bias and how to address expectations. Right? And there's 6 more. You'll have to invite me back for the rest.
Stay tuned.
And so one last point. So to warm up, we're the last visit here. If everyone can warm up, I'd like you to just point with your arm to the largest truck on the screen. If you could all point to the largest truck on the screen. Okay, great. Now my next question is, are you sure? Are you sure you pointed to the largest truck on the screen? Yeah? Take your hand and look at the size of each of them. What you're going to recognize, and you'll have to take my word for it, it could be on the screen. Usually with a patient, it's on their computer screen if I'm seeing them remotely. But I can tell you without a doubt that each of those trucks are the same size. So why am I showing you this optical illusion? By the way, cognitive, according to Daniel Kahneman, who just passed away, kind of one of the great psychologists of our time, cognitive illusions are even more powerful than visual illusions. This is a visual illusion. Cognitive illusions are what Sandra has prevented us with today. She has an automatic set of thoughts that came to her when she got on the scale and didn't see the results. She had automatic thoughts coming to a doctor to talk about her weight. Why I show this photograph is because I'm going to invite all of you to consider humility. Just because you told the patient this is a real disease, not their fault, and treatment exists, and about the concepts of best weight, that is not going to be, Sandra, you said it perfect. This is going to take time for me to wrap my head around. There will never be a time in your future that you look at this photograph and that the first impression is not that the one in the back is the biggest. There's nothing you can do about it. It's a trick in your brain. But you now will have a second line of thinking which says, oh no, I've seen this, Macklin put it on the stage, they're all exactly the same size, this is an optical illusion. That's cognitive restructuring, that's cognitive behavioral therapy. To have an automatic line of thinking and help the patient know that they have an automatic line of thinking and that their work isn't to get rid of it. You guys are never going to look there and think that they're all the same size at first, but you will at second thought. And that's cognitive restructuring and cognitive behavioral therapy is Sandra will slowly learn that these automatic thoughts that she's subject to when she gets on the scale, or if she sees herself in a mirror, or if she has an off-track day, or if she's presenting to a primary care physician about weight, the first and automatic thoughts, it's natural that they come, they never go away. So I wanted to leave that as a humiliating, rather a humbling kind of concept. Please, as practitioners, understand this has been years and years and years of lived experience of being the target of stigma and bias and discrimination. And you're not going to, that's not going to go away right away. So that's why repetition is such a critical part of the behavioral chapter. And I wanted to close by leaving Sandra a little bit of time to kind of talk about, again, the contrast in experiences between, let's say, a progressive clinician in obesity medicine versus what you've experienced in the past, and any final thoughts about that?
Yeah, I think it's, just to go back to the scale, and right now, I'm a patient advocate, and I feel like I know so much in this space, and I advocate for people and myself, but there are still times that I sit across from a doctor wearing a white coat where I somehow lose my voice and I'm not able to ask the questions or I'm not able to challenge. And I remember seeing a doctor just recently and she's like, oh, I need you to, you're a new patient, I need you to hop on the scale. And I said, no, thanks. And she got really upset with me. And I just, like, this idea, like, it's my body, my choice. And I felt in that moment, I didn't need her to know at that time. There was another time I did it at a hospital and I said, I'm going to turn around because I don't want to know. And she said, that's fine. And then she told the nurse beside her my weight. I'm like, I can hear. I might not see it, but I can hear. So just letting, I think what's really important is empowering patients, making it feel like a partnership so that it doesn't feel like I'm being told what to do, knowing that I also have some knowledge that, yes, I'm struggling in this area of my life, but I may have success in other areas of my life, and making me feel important. I think one phrase that you used when you were paraphrasing, summarizing to me was, it's really important that I get this right. I think that's what got me very emotional, to hear that it was important to somebody to get my story right, and to want to hear my story, because I'm more than a disease called obesity. I have a story. I want people to understand how I got here, what is unique about me, what is unique about my journey, what's nuanced about me, and have me be treated as a whole person.
Well, thank you, Sandra. Much appreciated. Yes, really appreciated. So we see that patients have automatic thoughts, bias, and stigma regarding their struggle with weight and their ability to lose weight. And here we've demonstrated using motivational interviewing to foster this kind of supportive, especially the summary, right? Miss the summary at your peril, right? Right? That's a take-home message for sure. And we kind of demonstrated how to implement a patient-centered care approach by leaving homework and leaving Sandra to decide, and inviting the patient to consider, one, that obesity is a real disease that's not her fault and treatment exists, and finally to consider the neurobiology of obesity and how the brain defends against fat loss and the overarching best weight concepts that we can share with patients as an invitation in form, kind of the equivalent of what we were hearing earlier about a FAQ. Right, that clinicians can benefit from. So thank you for your attention.
David Macklin, would you allow me to add one more key message? So there's something about the energy that a clinician brings into the room, and I found this clip of Dr. Macklin and the way that he often comes into clinic that I think will be inspiring for everyone. If we could play that clip for everyone to see. One more time, yeah.
Okay, that's great.
Really disarms a patient when you walk in like that, just so you know.
I'm going to try practicing that, but there's no way anyone can come close to that. Right. That was really impactful. Thank you so much. What we'll do for the sake of time is we'll probably have Dr. Habert's presentation, and then we'll have all of you on the stage together for a panel discussion. That's okay. Awesome. So last but not the least, let's have the rubber meet the road here. You heard a lot of concepts today, and for some of us, we are all very busy clinicians. We are trying to figure out how we can actually make this all happen in a 5-minute, 10-minute conversation with the patient. So to do that, we have Dr. Habert here, and Dr. Habert, of course, is our chair for the program today. He is a family physician in Thornhill for the last 34 years. He is an assistant professor in the Department of Family and Community Medicine at the U of T. He's also an investigating coroner for the City of Toronto. He's the co-editor of the Canadian Primary Care Today journal, and he's a former peer assessor for the College of Physicians and Surgeons of Ontario. He has participated in a lot of different guidelines as well as continuing medical education programs, and he's currently serving as a reviewer for the 2023 CanMed MTD guidelines, and has been also invited to join the Dissemination and Implementation Steering Committee of Diabetes Canada. Dr. Habert.
Thank you. You know, it's so hard to go after Macklin. I don't even know what to do with myself here. So originally when I was asked to do this talk, they said, okay, we know the average family doctor's visit is 9 minutes. We're going to do 9-minute clinical visit. And I said, that's fine, but you got to give me like 15 to talk. So they changed the title to a 15-minute, but in fact, the primary care physicians in Canada have 9 minutes. Obesity, as we understand, and overweight affect almost 2/3 of our patients. So every primary care practitioner in this country sees patients that suffer with this illness. And I think it's important to understand that this is something that we need to treat in our offices. So we've seen some of the best obesity specialists in the country today, and they've imparted us with great knowledge. But this is a disease for us to treat in our offices, and we have to learn how to do it. And we hear the same thing every time: I don't have time, I don't have time, I don't have time. And we hear about that with multiple things. We hear about that with depression. We hear about that with anxiety. I mean, we hear about that with everything. And we need to make the time because it's so important. And I'm not going to suggest at all that we do this in the 1 9-minute visit on average that we have. We can do it in 2 or 3 visits. But I wanted to do a very high-level summary, like 30,000 feet summary of a lot of the stuff that we've heard today. And I think one of the important things, I mean, Sean said this morning is, me too, I'll admit that as recent as 6 years ago, I was fat blaming, I was fat shaming. I mean, I'm embarrassed of the way that I treated some of these patients, and I see them now, and I remember saying, oh my God, you have to lose weight or you're going to this or you're going to that. So I take the blame. I've learned, and I think the new ways have taught us a lot better. These are my disclosures. So I want to talk about time-efficient strategies for obesity management in a 9-minute clinical visit. I want to talk about patient-centered approaches to address their individual goals and motivations. And we want to talk about effective treatment plans tailored to the patient in front of us. So let's meet Melissa. She works for Revenue Canada. Yikes. And yes, of course, she has wonderful drug benefits. The best, everything. She's struggled with her weight since her teens. She exercises 3-4 times a week. She goes to the gym. She's tried Atkins, Noom, Weight Watchers, and has been to numerous dietitians. I know what I need to do, and I do it. I mean, this is what she tells me. All my friends are talking about these new weight loss meds, and I'm wondering if I could try one. I mean, we've all heard this story in a primary care practice. By the way, it's Monday at 4 p.m. I've probably already seen 30 patients. I'm exhausted. She has a past history of hypertension and generalized anxiety disorder. She's on Prindopril 8 and desvenlafaxine 100 milligrams. So here's some of her vitals. Her blood pressure is 132/78. Her BMI is 30.4. LDL is 2.4. Fasting glucose, not bad. A1C is not bad. And kidney function is fine. What do we do with Melissa? Remember, we're talking an average of 9 minutes. So again, and you've heard this, I was trying to count, but certainly close to 10 times today. Obesity is a chronic disease, not unlike hypertension or diabetes. And I always use those 2 examples because primary care practitioners are very used to treating hypertension and diabetes as chronic illness. So it requires a long-term plan. It's relapsing. The body will defend against weight loss. So it's a long-term thing. So weight loss is usually followed by weight gain. It's multifactorial, as you've heard, with a very strong genetic feature, but it's a very complex illness, and it's progressive. I mean, it can progress over time. You've heard today that through the life cycle, it can progress. And numerous, not only the CMA, WHO, and multiple organizations have classified it finally as a chronic disease. It's amazing that this was only classified so in Canada 9 years ago. I mean, that's mind-boggling if you think about that. But to me and to all primary care practitioners, chronic disease means long-term management with risk of relapse, like hypertension and diabetes. You've also seen this today, that counting calories is not enough to achieve long-term weight loss. So decreased caloric intake, increased expenditure does not increase long-term weight loss. And it's funny because if I have a resident or a med student with me and I tell them, you never tell a patient to eat less and move more, and they're shocked, and then I need to explain what I mean by that. We know that a lot of obesity, as you've heard today. Obesity is a brain disease. I mean, multifactorial, but it certainly comes from the brain. And we don't tell patients to eat less and move more for weight loss. We tell them to eat less and move more for general health, and we can get into that. You've seen also that the body is really, really smart. It has its weight, and it defends against losing weight. So you lose it, it is working really, really hard to gain it back. There's hormonal adaptations, as you've heard. There's the satiety issues. There's the fullness issues. There's this thermogenic adaptation, which is interesting. And it's been interesting because I follow Dan Drucker in the last few weeks. He's been posting a lot about thermogenic adaptation and how GLP-1s seem to decrease that. So that's another way that GLP-1s will work. So what in fact happens is your resting loss of energy will go down if you lose weight to try and conserve weight and gain it back. Very, very interesting. We know that, yes, you can have lifestyle interventions, and you've heard on average 3 to 5% or 1 to 5%, but I mean, we've seen success. I mean, I was very big on Atkins and Noom in the old days, and I've seen people lose 10% or 12% or 15% initially, and they can all do that with hard work. The problem is the regain. Look 2 years down the road, look what happens. Many of you have seen the data we have from the TV show The Biggest Loser, and they get that big dip. So we know that in the long term, your body will defend and it will come back. So it's more than just lifestyle changes, as you've heard numerous times today. You know, thank you for that, guys. It was exceptional. And it's different than other diseases because I mean, sort of ask, but I ask for obesity. We always ask, and it's important to ask because if I don't ask, I'm going to lose and it doesn't work. And it's different than other illnesses. I don't actually ask to treat hypertension. I mean, it's a bit of a different thing. I explain it in a different way. I do think obesity as a chronic illness is unique in that regard. The ask has to be a sincere ask. And I think more importantly than the ask is the listen, as you just said. And thank you very much for the summary, because I think that's so important. We're not going to go through these because we don't have time, but the ask is so important. And I've learned that with all my failures of patients from 15 years ago when I was telling and not asking. And when you start asking, they're going to say no many, many, many times, but they're going to come back. And they're going to be asking you for help because you've asked them, you've given them permission. So it may not be today. They're going to say no, but they'll remember you ask. So the ask is very important. This is the assess. The other thing we have in primary care, we know our patients. Like we've known them for 5, 10, 15, 20 years. So a lot of the history we know their circumstances, we know their life, we know what they do, we know their family history, we know their medical history. So the assessment for us is actually many times a lot easier than it would be for an obesity specialist. Psychiatric drugs, I mean, my passion, I have a lot, I do a lot of mental health. We're about to launch the Canadian Depression Guidelines 2024. It's been 8 years. I'm highlighting these drugs because we often use drugs that cause a lot of weight gain. And I'm not saying these drugs are better antidepressants, and we stress it in the guidelines, not better, but they're certainly better for weight gain. A teaser, brexpiprazole, has now been elevated to the only second-line drug, essentially, with aripiprazole, and I highlight brexpiprazole because it's weight favorable. And then I highlight these 3 antidepressants that I have there, desvenlafaxine, vilazodone, and vortioxetine, as being the most weight neutral. I could highlight bupropion because it's quite weight neutral, but it's a whole different story that I didn't want to get into. It's not the most effective antidepressant, so I didn't want to highlight that. Weight loss goals, you've heard a lot about that, and it's setting and talking about the best weight. And I think important to talk about small amounts cause very significant physiologic benefits, as we've seen with fatty liver and sugar and hypertension. And the patient goal most often doesn't match with our goal, and we need to actually discuss that at the outset and set a proper goal. Once again, talking about the expectations. The other thing I do find is I do like to tell the patient the average because they'll ask, but I would rather say that 2/3 of patients will lose 10% in this trial, or 2/3 were seen to lose 5%, whatever the trial shows. Then I'm not really held to a number when they come back in 4 months and say, hey, you said the average weight loss was 16%, but I only lost 13%. If I said, you know what, 70% of patients lose more than 10%, I think it's a more realistic goal for the patients. The pillars, you've seen them, they're wonderful, and you realize the 3 pillars that we've been talking about all day support medical nutrition therapy and physical activity. And it's important, as you've seen with medical nutrition, to do what you can sustain. For physical activity, it's food for the brain and food for the heart. We really need to emphasize, we're not telling our patients to exercise to lose weight. We're telling them to exercise to feel better. And in the depression guidelines, we strongly highlight exercise. Again, we try, because it's very hard to get patients with obesity exercise. It's very hard to get patients with depression to exercise, but it's so important. Alyssa did a wonderful job. You heard her talking about medical nutrition therapy. Once again, don't tell patients to eat less and exercise more for weight loss. There's a lot of factors involved, and they need to focus on something that can be sustained long-term, whatever works for them. And there's many variations of what works for individual patients. We know that diets, it's funny because I've seen this slide and I had to change the language because this slide originally said diets don't work, and I actually felt I probably shouldn't use that. Diets don't promote long-term weight loss as a softer way of doing it. This is a meta-analysis. We've seen multiple meta-analyses, and we're not throwing it out because I've been accused. Are you saying we shouldn't diet or exercise? And I never say that. I'm saying it's part of the overall goal, but lifestyle changes on their own do not promote long-term weight loss, and that's what we're saying here. And this, we talked about nutritional management. You've heard it through the day. One size does not fit all. We really need to tailor it to the individual patient sitting in front of us, because the patient we're seeing now is very different than the patient we saw with obesity an hour ago, with different goals, different wants, different needs. So it's a very different game from patient to patient. This is talking about physical activity, and once again, the benefits of physical activity beyond weight loss. So, obesity pharmacotherapy factors to consider: their history. What have they done? What's gone on? What does their weight look like? What are their comorbidities? The beautiful thing about primary care is we know a lot of these answers. We've known them for decades, so it makes it easier for us. And once again, need to consider, what does the patient want to do? And the tools in our toolbox are mounting. There's a lot of them, and there's going to be a lot more in the next few years. We need to discuss those options with our patients, because once again, one size doesn't fit all. You've heard about the 4 approved drugs for weight management in Canada, with many, many more to come. And role of pharmacotherapy, you heard it works in the brain to increase hunger-signaling hormones, decrease satiety. When we lose weight, these are the bad things that happen. So we know the body's always defending, and the weight loss drugs defend against this. And then there's this thermogenic adaptation thing, which is very, very cool. And we'll probably hear more about that in times to come. It's part of the overall treatment of our patients with obesity. So the patients have tried lifestyle behavioral changes. You've been talking about it. You've asked for permission. They are asking you for help. So we need to try and help them with something that will work for them. Expectations, I mean, you've seen this slide also. Lifestyle modification alone, less than 5%. Average expected weight loss with the different drugs that are approved, 8 to 16%. Bariatric surgery, let's say 20 to 40%. So very different, once again, tailored to the individual patient. You saw this, Mega showed us this earlier today. These are the average changes in body weight with the therapies. And once again, I don't mind using the average, but I think in addition, I always give the cohort numbers, like 70% of patients will lose over 10% or whatever the numbers would be. And these numbers are hugely impressive, especially with the new therapies. And this is the responses to pharma. I mean, so these are the numbers that I would like to use. Like, I could safely say with semaglutide high dose or Wegovy, 70% of patients in the trials lost over 10% of their weight, and so on and so on. So back to Melissa. She's given you permission. I mean, you've known Melissa for 20 years. You've watched this journey. She's followed the pillars for years. She's very motivated. She's actually given you permission. She's come in giving you permission. You set realistic weight loss expectations. In the clinical trials, X% of patients lost 10% of their body weight would be an example. In her case, we decided to prescribe semaglutide starting at 1/4 milligram weekly, so on and going up. I arranged follow-up in 4 to 6 weeks to see how she's doing. See how she's doing. I don't actually care about her weight. I care about how she's doing. Like, I actually want to know how she feels. She may feel great. She may not tolerate the drug. She may not understand how to use the drug. So that visit isn't to talk about her weight per se, the number, it's to talk about her. And then I will see her again. It's a chronic illness. I'm not giving her the drug and saying, go away forever. So I want to see how she does. We talk about her goals. We talk about titrating the dose of whatever drug we choose to match her individual needs. And I think that is the end of my little quick story. But I think the most important thing to remember is this doesn't need to be done in one primary care visit, often done in multiple visits. And that's it. Thank you.
Awesome. So I'll invite the audience, if they have any questions, to come up to one of the 2 microphones here. Lots of really good discussion here. Thank you so much for your insights. Let's start with the online questions in the meantime. So the first question is for you, Sandra. How would you feel about the waist to height ratio compared to having your weight taken?
Yes, I would prefer it as a person who carries most of her weight in her hips and butts and thighs. So I know that there's less metabolic risk with that. And I think that's an important message, especially when we consider women from different cultures, that you can have an elevated weight and have no comorbidities and be totally healthy, which means we just got to get over this idea that there's only one body type that equals health. So I do prefer that measurement for sure.
That's really good to note. And just as a quick point, there can be a lot of inter and intra-observer variation in the measurement. So it's a good point to assess how you're checking for the waist circumference. And also in Canada, of course, we've got lots of patients that walk into the clinic wearing their heavy jackets, coming out from the parking lot. So it's important to make sure that, they're taken in a separate room where the waist circumference is being measured, just as we would want to do a weight check if you're doing that. Great. So question for either Jeff or David here. Where would you direct patients to for good information on obesity as a chronic disease?
The guidelines, the Canadian Clinical Practice Guidelines, I would.
I agree.
Yeah.
And it's written in I like the language of Obesity Canada. I think they get, Steve Glazer mentioned it before. OBN has some great information, even for patients that aren't considering surgery. Remember, there's a medical program. I use the OBN website. I use Obesity Canada.
Yeah, and I want to add Obesity Matters, which is a nonprofit organization that advocates for people living with obesity, and our mandate is to educate, empower, and advocate for. So that's another great resource for your patients.
Excellent. Thank you so much for that. What does the CBT or the behavioral change mean in the motivational interviewing discussion that you had?
So this might sound like a little bit of a somersault, but in theory, there's only 3 symptoms to obesity. I'm floating this, okay, so bear with me. One is this powerful, conditioned, biological drive and motivation to food, which medications and surgery treat. Another key symptom that goes unnoticed or unrecognized is where CBT lands. The idea is that humans have automatic thoughts that happen in circumstances. This is a foundation in depression and anxiety, but where it applies to obesity is as follows. If you want to have an understanding of the thinking and where CBT will apply to your patients, think of 2 sets of circumstances. Think of 1, your patients will experience setbacks. please normalize that in a path forward of managing weight, they will interpret certain events as setbacks. They might not be setbacks, but they will interpret certain events as a less than perfect eating day. If they choose to weigh themselves, getting on the scale and having it be a number not in their favor. If their clinician is doing their waist height ratio and they get a measurement that's not any better than it was last time, seeing their image in a mirror or in a photograph. Here's a category of events which we would call it can be interpreted as setbacks. Would you be surprised to know that in those moments, your patients will experience what could be characterized as a storm of automatic thoughts that speak poorly about themselves and their capacity to manage their weight from a lifelong of being the target of stigma and bias. And so a key part of CBT is it's actually the acceptance-based and commitment-based therapists. And I want to simplify things. Is that something you guys could do? Could you invite your patients to consider that they're going to experience setbacks, and that's normal, and that in these moments of setback, they're actually going to have an automatic set of thoughts that speak poorly about themselves and their capacity to manage their weight. And their homework is actually just to notice it, to gain actually some distance from, oh, I'm having one of those moments, right? I just had a crazy, what I feel is an off-track weekend, and I feel like crap. I feel frustrated, I feel this is what Macklin was talking about, where I have these automatic thoughts. And so CBT is helping them ultimately recognize those thoughts and make changes. And by the way, the only other place with automatic thoughts is in a moment of choices around food, right? Automatic cognitions, well, it's been such a long day, I'm so stressed, I'm tired, this will make me feel better. You know what, I'm not really on track anyway, so what difference does it? Automatic thoughts in moments of wanting that will come and give permission and reason why someone should go ahead with an eating behavior. Again, the homework would be just recognizing these thoughts. Would you be, surprised to know that in moments of eating choices that you may be subject to automatic thoughts? And CBT is just recognizing and even potentially changing those lines of thinking. What does it sound like? Sure, I could eat this, but you know what? It's not really aligned with my values. It's not in the direction that I want to be going. I'll actually feel better if I don't. This won't relieve my stress. In fact, I might feel more stressful afterwards. And by the way, surgery and medication give patients a lot more space to pause and stop and have those changes in conversation. So that's where you see the link between behavioral therapy and other forms of treatment.
Great, thank you. Jeff, maybe I'll have you address this question. So how would you address when you have an individual on a GLP-1 therapy who has lost weight and their appetite has reduced significantly? They're eating very little, but they want to increase the dose of the GLP-1 in order to lose more weight. And would you increase it? And if so, would you anticipate them to have even more weight loss?
I mean, it's funny because we may have mentioned that. We talked about that before because that was one of the most common questions we got. What about nutritional deficiencies? And I'll admit I don't specifically screen for them, but I haven't seen nutritional deficiencies. And remember, as everyone's been saying, obesity is not only about an actual number. If they're not doing well in terms of a normal life on the dose of GLP-1, I'm not raising that dose. Treating obesity is not about losing more weight. Treating obesity is about being well, feeling well about yourself, feeling well every day. So, I mean, some would, I wouldn't at that point, and we talk about it, see what's going on. I would probably adjust stuff. Like maybe I'd actually even lower their dose a bit.
And I would say ultimately we can't necessarily have control over that because in patient-centered medicine, patients are going to not take medications. They're going to do higher doses than we recommend. Right. And so I wanted to step backwards actually in that concept. If we have framed this patient interaction and their path forward as them discovering this most modest, but yet still kind of most healthy, but yet still kind of sustainable, their work isn't weight loss. That might not happen if this patient is really coming to the idea that their goal isn't weight loss, and this isn't an anti-obesity medication. Their mission is to be finding this most modest lifestyle that's livable and sustainable and enjoyable and something that they could do for the next 50 years. If they're wanting to up their medication because they want to go to 800 calories a day, is this really something you're going to do for the rest of it? Is that, are you practicing the skills that are going to be complicit in your capacity to both lose and maintain weight, or are you practicing skills you don't really even need? And that could be risky. So I'd step back and hope that we framed their path not as a weight loss path over and over and over again. Remember, repetition is important. Yeah.
And Sandra and David, I'll have you address this from each of your perspectives. So we talked a lot about stigma, right? How should we help people living with obesity, normalize that talk about weight and avoid the stigma and anxiety when it comes to measurement of their body weight?
Yeah, so I think it's important to pick your doctors very carefully. So I have a family doctor that I adore. She's been my family doctor for 15 years, but I have a doctor that deals with my obesity because I see it as a specialty, and I need somebody who really understands the disease of obesity, and that's sort of where my GP is lacking. That's kind of her blind spot. In terms of not let it just be a number or a body weight, I think we're kind of ignoring the idea that this is really vulnerable. And, I've heard some people say, just keep getting on the scale so you desensitize to it. Well, that doesn't really work for me. I'm a person with emotions and a history and a story. And for me, it's just easier not to know that number. So empowering your patient to help them understand what's the best way forward. I often say to my clients, are you neutral about the number? Can you be neutral? Is it just a data point? Then fine. But if that number has the power to change how you feel about yourself, the way you see yourself in the world, if it derails your efforts, then maybe it's safer not to know. So that's the way I would leave the decision with the patient.
Yeah, I think that's a no-brainer. Thank you. What Sandra says, I agree 100% and endorse. I certainly don't ask patients about their weight. If patients offer their weight or choose to weigh themselves, that's really their decision. If a patient asks, should I weigh myself, or how often should I weigh myself, really the clinical question is, would you endorse that now or in the past, if you have been, in an effort to manage your weight, getting on a scale and you saw a number that was not in your favor, would you endorse that that has resulted in a negative emotional experience that's affected you? Yes. All the time, or it used to and it doesn't, or, right, you'll get the answer. And if, by the way, if the answer is, yes, I endorse even to now that it's a negative emotional experience, if I see a number that's not in my favor, then why is that person getting on a scale? And in effect, weight's not a behavior anyway. Let us focus on the behaviors.
A little bit different though in primary care, where I have 30 years of weights before we started talking about obesity. And there are many patients who say, I don't want to know my weight. That's fine. But there's many who are motivated by knowing their weight, and it's a positive experience. Even if the weight's up a little bit, okay, I know what I need to do. So you have to ask the patient. So I don't have a rule about not weighing patients at all, because many want to be weighed. And I have weights long before we discussed obesity, because I've been seeing them for decades. So
I love it. That's right. Would it be a negative emotional experience if you saw a number that was not in your favor, not in the direction you want to be going? No. Actually, I find that motivating. If I see a number that's not in the direction I want to be going, I double down my effort. I really enjoy that. It gives me a sense of where I am. Okay, great. We're learning from our patients, and we're listening and summarizing what they're telling us. Yeah.
So maybe as a final question here, we spoke about that brilliant concept of best weight, right? And this is an eye-opener to many of us here that, it's not about that target weight or ideal body weight, all that stuff that we are taught in med school. So when you're having your initial discussion with your patients, how would you frame what would encompass or determine that best weight?
So the best weight concept is very much rounded out around the concept of expectations, right? And so when Michael and I wrote this chapter, one of the key findings that Michael came up with was that he writes this really well in the chapter, where outlandish weight loss goals were not a determinant of how someone would do. It wouldn't determine more outlandish, the worse they do, you'd expect. What was the determinant in the clinical trials that we dug up was the level of satisfaction that a patient had with wherever they landed. That's the determinant. And if you want to know the signature, the clinical signature of a patient that is satisfied at their best weight, what the patient will say, and you hear this fortunately often enough in a good clinical practice, you hear the patient say, would I like to be 20 pounds lighter, 15 pounds lighter? Yes. But you know what I've learned? I've learned that the lifestyle that I would have to live to get there and stay there, I'm actually not interested in, because I actually like our weekends at the cottage, and we travel 3 times a year, and we go out to restaurants, and I mean, could I get there? Sure, but that's not a life I want to live. So now they're really describing an acceptance and understanding that they're finding their best, and it's actually not their best weight. It's really their best lifestyle, their most modest yet enjoyable lifestyle, and their weight's landing somewhere, right? And their body and their brain and their genetics are telling them, but they're accepting that. That's where you want to land, hopefully.
Excellent. Well, thank you so much to our panelists. That was very insightful. We really appreciate it.
Thank you very much.
Dr. Haber and I can probably.
All right. All right. Thank you, everyone, for attending today and staying this long. We really appreciate it. We really enjoyed our first obesity update. I want to remind you all, please fill out your evaluations. We really do look at them, and it really forms opinions for next year's programs and future programs to come. Once again, everyone be safe. I think many of you are coming back tomorrow for the beginning of diabetes update, which is not new. Actually, any other?
No, well, yeah, just wanted to say a big thank you to all of you to come out here today, especially with the weather being the way it is. And thank you to all our experts that shared their insights. And hopefully we're all going to be able to incorporate these changes in our practices starting tomorrow.
Thank you very much, everyone.